So thank you everyone for joining me today. My name is Colleen Fritsch, and we've come together today to help you learn more about dementia and Alzheimer's disease and creating a dementia-friendly environment for your patients who may be living with cognitive impairment. I am very excited to be here today because I think with just a few simple changes, together you and I can make a day better for a person living with Alzheimer's or dementia. And that's my goal today. I assume that some of you are here today to learn how to handle a situation when someone comes into your office and seems confused or upset. Or others may want to learn more about how to help someone that you know personally who is living with dementia. And others are here because their organization said this is important and we want you to attend. Some of you may have a lot of personal or professional experience dealing with people living with Alzheimer's or dementia. And for others, this may be your first formal learning about this. But regardless of where you're starting, the goal is the same. The goal is for you and this amazing team of yours to learn something new about creating a safe and welcoming environment for patients who may be living with cognitive challenges. So today, here's what we're going to cover. We're going to cover some facts about dementia and the warning signs of Alzheimer's disease. We're going to go over some communication tips and strategies and do a planning activity to start trying to put some of the pieces together as we go. Then we'll talk specifically about how you might be able to create a dementia-friendly environment there at your workplace. We'll do a case study. Again, this is all about putting it together so we can move forward. Then I'm going to share some resources and services that are available to you and your patients. And then at the end, we're going to end with a call to action. So in front of you is your dementia-friendly at work for healthcare participant guide. I hope you have all had the opportunity to print that out and have that in front of you. And I'll try and keep you along with me as we go through that participant guide. So if you'll turn to page 2. Let's start, before we get into the facts and statistics, let's start with where we are right now. Could I ask each of you to just shout out one word that comes to mind when you hear the word dementia? No big deal. Jen, why don't we start with you? What one word comes to mind when you hear the word dementia?
Confusion.
Confusion. John, what word comes to your mind when you hear the word dementia?
Depression.
Depression. I hear that. Lolly, what word comes to your mind? Uh-oh, we're back to not being able to hear Lolly.
Can you chat it?
Yeah, good idea. Thanks, Jen. Lolly, would you put it in the chat feature? Uncertainty. And Jess, do you have one word to share with us that comes to your mind when you hear the word dementia? Stressful. I hear that. And Michelle, thank you for joining us. Can you give us one word that comes to your mind when you hear the word dementia?
Difficulties with thinking and memory.
Thinking and memory. Fair enough. So just in general, you heard confusion, stressful, uncertainty. Were these words mostly positive or negative? Just give me a thumbs up or a thumbs down. Yeah, you're right. These words are mostly negative, and that happens whenever I ask that question. And so here's my question. Can you think of for a moment about how it might impact your interactions with people with dementia if you go into that interaction with that preconceived notion? It's just a thought. And maybe today, as we go through this presentation, we'll begin to chip away a little bit at some of that. How many of you, again, simple show of hands, how many of you have known someone living with dementia? Oh, we're unanimous today. So most of you, all of you have known someone living with dementia, and the positive and negative exercise we just did may shed some light on the stigma around it. Let's review some facts. Let's start with facts. Let's review some basic facts about dementia. And let's start with this. Do any of you know the difference between Alzheimer's and dementia?
Well, I think I do. I think that dementia is more of a blanket term and Alzheimer's is a type of dementia.
Absolutely perfect, Jen. Thank you. So dementia is an umbrella term that covers many different diseases of the brain. But of all of those different diseases of the brain, the number one form of dementia is Alzheimer's disease because it accounts for 60 to 80% of all of the cases of dementia. But there's still, you've maybe heard of frontal temporal dementia or dementia with Lewy bodies or vascular dementia. There are many others, but all of them all of them are a disease that will one day impair a person's ability just to complete everyday tasks in their life. So on page 2 of your participant guide, there are some facts for us to take a look at. Alzheimer's disease is the leading cause of dementia, and Black and Hispanic Americans are at greater risk than white Americans for developing Alzheimer's. That's likely due to health and economic disparities, but it's just interesting to note, and it might be informative in your practice. They are also less likely to be diagnosed. Women are twice as likely as men to have Alzheimer's disease. Anybody have any guess why? Because they live longer. So the number, believe it or not, sadly, the number one risk factor for getting dementia is getting older. And so by virtue of the fact that women live slightly longer than men, women are at greater risk or higher potential of developing Alzheimer's. Overall, 1 in 10 people age 65 and older, and 1 in 3 people 85 and older have Alzheimer's disease, diagnosed or undiagnosed. That's a lot of people. Unfortunately, Alzheimer's is probably much more common than we have realized in the past. So now, thinking about those statistics in your practice, let's think of all the patients in your clinic who are 65 and older. Statistically speaking, 1 in 10 is likely to have Alzheimer's disease. Research also shows that of all those who meet the diagnostic criteria of Alzheimer's, fewer than half have received a diagnosis. This means that it's likely you may have patients who are actually living with Alzheimer's or dementia, but they haven't been diagnosed and do not have a diagnosis on their medical record. So you might know when they come in. So how does this affect your work? Let's just think about it. Let's imagine that you are a provider, a dental hygienist or a dentist, and you see 10 patients a day. That's 50 patients a week. If 20% of those are age 65 and older, that's 10 people you see in a week that are age 65 and older. That means that one of your patients every week will likely have Alzheimer's disease, whether they know it or not. On the other hand, if you're the receptionist, you may be seeing 50 patients a day, and that's 250 patients a week. If 20% of those are age 65 and older, that's 25 people. 2 or 3 of those patients that you see every week will have Alzheimer's disease, diagnosed or undiagnosed. This represents a real opportunity for your dental clinic working with older adults, being alert for the signs and symptoms, facilitating a dementia-friendly workup when appropriate, a dementia workup when appropriate, and giving patients access to diagnosis opens the door to them for information and support, which they won't have if they don't know what they're dealing with. It allows patients and family to better understand the symptoms, know what to expect, learn how to cope, and where to get help, live more safely, and plan ahead. So let's begin. In your guide on page 3, you will see a table with the left column listing the signs and symptoms of Alzheimer's. And on the right-hand column are examples of what you might see in your office. So how do these early signs and symptoms of Alzheimer's disease relate to what you're seeing? If you see these signs, it doesn't mean that someone has Alzheimer's disease or a related dementia, but it is a red flag and an indicator that a full dementia workup might be needed, or at least a referral to a doctor who can provide that service. Because these examples represent changes in a person's cognition that are not explained by aging alone. So the first sign or red flag is memory loss that disrupts daily life. We're being honest, you forgot things when you were 10 years old and you forgot things when you were 30 years old. Forgetting is normal. That's not memory loss. A memory that is lost. So that would be simple things like learning how to operate a new remote control, right? And all of a sudden it just doesn't make any sense. Or forgetting important dates or events, or repeating themselves even in a short conversation while they're in your office, or asking for the same information over and over, or needing to rely on someone for help with simple things that they used to be able to do for themselves, like, what's your date of birth, ma'am? And I'll turn to my husband and look for help. So what you might notice in the office is a patient tells you they're having trouble remembering things. And if they tell you they're having trouble remembering things, chances are it's more than just forgetting. Or a patient forgets the reason for their visit. Or again, a patient looks to their spouse for answers to questions that they've always been able to answer in the past. The second sign is challenges in planning and solving problems. One of the areas of the brain eroded by this disease is the part that does step 1, step 2, step 3, step 4. So they may have trouble developing a plan or following a plan. And we're going to talk a little bit more about that later, because we're not expecting people with Alzheimer's or dementia to create an architectural drawing, but we do expect them to be able to do some planning in their day-to-day activities. And so we're going to spend a few minutes on that a little later. They may also have difficulty concentrating or keeping track of their monthly expenses, and it might take longer to do things than it ever has in the past. What you might notice is that the patient tells you she's having trouble brushing her teeth because the new automatic toothbrush just isn't working right. Or they may be unable to follow a new treatment plan that you're working on with them that has multiple steps. The third sign is difficulty completing familiar tasks at home, at work, or at leisure. As the disease progresses, people with Alzheimer's often find it hard to complete daily familiar tasks that they've done all the time. They may have trouble managing medications, driving to a familiar location, or remembering the rules of a favorite game. In your office, what you might see is a diabetic patient unable to show you how they prepare their injection and their regular doses of insulin. Or a patient gets lost finding your office, even though they've been coming there for years. The fourth sign is confusion with time or place. Sometimes a Tuesday looks a whole lot like a Wednesday, doesn't it? But for a person living with Alzheimer's or dementia, it's more than just not being sure of what day it is. It's not being able to figure out what day it is. They lose track of dates, even the passage of time and the changing of the seasons. As the disease progresses, they may forget where they are or how they got here or where they got here from. In your office, you might notice a patient misses one or more appointment, and when you call for follow-up, they don't even remember they had an appointment. Or a patient asks if they can use the restroom during a visit. You escort her to the restroom, which is right next door to the exam room, and ask her to return when she is ready. And she doesn't come back. 15 minutes later, you find her wandering in the hall. The fifth sign is trouble understanding visual images and spatial relationships. A person with Alzheimer's disease doesn't develop vision problems, their brain develops problem processing the images. And so oftentimes they will either lose their peripheral vision or they will lose their depth of field. They'll have difficulty reading or judging distance, and determining color and contrast can be a big issue. And of course, that isn't going to help their driving ability any, is it? For example, someone may not be able to see a black pen on a black countertop, or a black rug on a white floor might look like a hole. We just need to understand that these vision changes are happening and help them through that. So what you might notice is a patient comes into the office and says they fall frequently down steps or on the pavement at home because they can't see where the steps are, or they can't see, if they've lost their peripheral vision, they can't see an item that's next to them, so they might trip and fall over it. An existing patient might have difficulty figuring out how to even sit in your dental chair on the exam table. Or a patient begins to have trouble inserting their dentures that they've worn for some time. She can't figure out the proper orientation anymore. And all of that might be because she just can't see her dentures correctly anymore. So the sixth sign is new problems in speaking and writing. People with Alzheimer's have trouble following and joining a conversation because sometimes the words are just flying past them too fast. They may stop in the middle of a conversation and not know how to continue. They may struggle with vocabulary, having trouble finding the right word, and sometimes making up a word like hand clock or that liquid pencil thing, right? Trouble with words makes it trouble for them to be part of a conversation. And so we just need to understand that and be helpful. So what you might notice is that a highly educated patient is not able to read their after visit instructions, or a patient tries to ask a question but can't find the right words and becomes frustrated. Or a patient asks you, stop touching that thingamajig, that what do you call it, right? The seventh sign is misplacing things and losing the ability to retrace their steps. We all lose things, our cell phones, our glasses, our keys, right? But we can retrace our steps. For that person with Alzheimer's or dementia, the ability to do that is gone because that's a recent memory and that's been eroded by this disease. People with Alzheimer's disease may put things in unusual places. I know things get stored in the freezer. I'm going to put this in the freezer. Uh-oh, that was my car keys. Might have trouble finding my car keys later. They may lose something and not be able to go back over their steps. And sometimes they may accuse others of stealing. This may occur more frequently over time. You know, if I can't understand all of the visual images going around me, and I can't understand all of the words going around me, and all I want is my cup of coffee, and I can't find my cup of coffee, I might very well say, John, where did you put my coffee? So what you might notice is something very similar to that. When a patient leaving the office, they return in a panic because they can't remember where they parked their car, or even if they drove to the visitor, if they're waiting for someone to come pick them up. Or a patient sets down her purse or her phone on a chair in the corner of the exam room, and after the visit can't find it. And again, that might be a time they accuse you of stealing it. Or a patient repeatedly loses or misplaces their dentures. The eighth sign is decreased or poor judgment. People with Alzheimer's may experience changes in judgment or decision-making. For example, they may use poor judgment when dealing with money, such as giving large amounts to telemarketers. As the disease progresses, they also may pay less attention to their personal grooming. So what you might notice in the office is that a patient shows up for the office wearing a short sleeve shirt and no sweater or coat on a cold winter day. Or a patient tells you that he has been soaking his dentures in bleach to try and brighten them since they look stained. Again, not good judgment, but they're doing their best to solve what they think what they perceive as a problem. The ninth sign is withdrawal from work or social activities. And maybe we understand that now. I can't take in all the images. I don't understand all of the words. You know, when I'm here in my own environment, I know what's going on. When I get out there into the world, it gets a little frightening. So people with Alzheimer's or dementia might start to withdraw from hobbies and social activities, work projects and sports. They may have trouble keeping up with a favorite sports team or remembering how to complete their favorite hobby. They may also just simply avoid going to social activities because of the changes they're experiencing. So you might notice that a patient tells you that I don't cook anymore because it's just too much trouble. Or a patient tells you he can no longer get together with friends because they only talk about things that I don't like to talk about anymore. And maybe when they tell you that, there's something else going on. The 10th sign is changes in mood and personality. The mood and personalities of people with Alzheimer's can change. They can become upset at home, at work, or with friends, or in any place out of their comfort zone. Remember that any words or actions should be viewed as an attempt to communicate. If the person you're talking to is angry, maybe something has made them angry. If they're depressed, maybe there are thoughts in their heads that are making them depressed. So if you will understand that what you and I call behaviors might really be an attempt to communicate, maybe we can begin to understand them that way. There are many reasons why a person might not be able to communicate directly and may use their actions instead. So what you might notice is someone who has always been easygoing and talkative during visits now seems quiet and withdrawn. Or a patient who has always been friendly now seems impatient, irritable, and has angry outbursts for no apparent reasons. Have you guys seen any examples of any of these 10 early signs in your practice on a day-to-day basis? Lolly and Jess, feel free to chat. The rest, if you just want to speak out, that's great.
Yeah, I think that one of the things that I've seen is the idea that people cannot follow the directions that you give them when they've been at the dental practice for several years and seeing the same dentist, and yet they have trouble with being able to keep their mouth open, to turning when you ask them to turn, and actually when you're putting the thing in your putting it in your mouth to release the water from the mouth after filling that's been an issue that people just don't know what the reaction is. The reaction is normally automatic, but even automatic reactions are a problem.
Great. I understand that, and I see how that would work, John. Thank you. Anyone else?
I've seen people have difficulty figuring out how to get in and out of the dental chair. People who've been our patients for many, many years and have been able to do that in the past and really struggle. I mean, it is a different chair, granted, but it is an ability that they've had in the past that I've seen change.
So, and in all honesty, I have to tell you, those chairs are a little weird. Just
Yeah,
being honest.
they are.
So maybe if you like pat on the seat and say, you want to just sit here and then put your feet up over and then swing and put your feet, give them simple instructions just so they know that. I mean, I can't imagine if you don't know where to start, how do you even address that long slinky thing?
I've seen, it's not uncommon to see people come in on the wrong day, but I've had people come in 3 times in 1 week and they don't have appointments that week.
Wow. Well, I hope we're going to be giving you some tips today that can help you in
That'd be
dealing with
great.
those situations and trying to figure out what's going on with that. So let's move to starting to put some of this understanding together in how to communicate with a person. Our ability to express ourselves, our desire to understand and be understood is a basic human need. We all want to be heard and feel understood and valued. But Alzheimer's and other diseases cause dementia damage and other diseases that cause dementia damage areas of the brain responsible for communication, both expressing the needs and understanding what others are saying. This can feel a bit like having a conversation in a language that you studied in school, but you don't speak fluently anymore. If you've ever done this, you know it takes a lot of effort. It's exhausting. And it's often very frustrating. And it's especially difficult if people are moving or if they're talking too quickly. Think about sitting in a room with a bunch of people who are speaking a different language, a language, though, that you studied in high school. And then having to come up with a response when they ask you a question. In fact, this takes time. It does. And in fact, it may take people with dementia up to 20 seconds to take in what you have asked, process that information, formulate a response, and then articulate a response. That can be a long time if you're the one waiting for the answer. Let me just demonstrate that. Jen, can you be my partner in this activity?
Sure.
Good. So Jen, I'm going to ask you a question and then I'm going to ask you to wait 20 seconds and I'll time the 20 seconds and I'll give you the heads up when you should answer. So Jen, do you have any plans for this evening?
I need to stop at the grocery store and get some vegetable juice.
Thanks. That was 20 seconds. How did that feel?
Awkward.
Long.
Long. Thanks, Jess and Lolly. I appreciate that you're still participating, even though you have to chat it in. That's lovely. It does. It feels like a long time. And did any of you want to help? Well, it's a Wednesday night. If you got any church activities, it's a beautiful evening. Are you going to barbecue? Are you seeing the kids? How about your grandkids? And guess what you're doing? You're piling on. This person really, really, really wants to be part of that conversation. They really want to carry their load of the conversation. But then when you start asking all the subsequent questions, they just give up. They haven't got a chance to answer all of those questions. But I bet you now that you know that, I bet you'd give me 20 seconds anytime I needed it. And I know I'd give it to you guys. All right. It reminds us to allow extra time for our patients who are living with dementia and are trying to communicate. And I bet you, some of our other patients might appreciate that 20 seconds or even 10 seconds that they might need to understand a question that you've asked. So although Alzheimer's disease causes brain changes that lead to communication challenges, many aspects of communication remain as strengths until late in the disease process. For example, people with Alzheimer's continue to be able to participate in give and take conversations and to read nonverbal and emotional aspects of communication long after their ability to understand and use words is impaired. This means that patients will increasingly rely on tone of voice, facial expressions, and body language just as much, if not more, than the actual words you use. That's probably the most important thing I'm going to say to you this afternoon, so I'm going to say it again. Patients will increasingly rely on your tone of voice, your facial expressions, and your body language just as much, if not more, than the actual words you use. So on page 5 of your guide, you'll find some additional communication tips in communicating with a person living with dementia. And let's go through some of those. Number 1, treat the person with dignity and respect. And I know you already do that, but this is just a reminder. Number one, because they deserve it. And number two, because they can tell in a heartbeat when you're not treating them with dignity and respect. So if I have dementia and come into your office and my husband comes with me, and you turn to my husband and say, is she brushing her teeth regularly? I might get just a little irritated. Is she having any bleeding on her gums when she flosses? My blood pressure might be going up. Now it's different if you say, are you remembering to brush regularly? And I look at my husband to give the response and he gives the response. But then as my care provider, then you come back to me and say, oh, Colleen, good. I'm glad that's working out for you, right? Because I'm the patient there. And I got to tell you, I'm one of those people who get a little irritated. All right. Be aware of your feelings, and that might sound a little strange, but be aware of your feelings and how they're transmitted in your body language, your facial expression, and your tone of voice. So I'm having a bad day. We're behind schedule. My next patient coming in, I know is one of those cranky young kids that never wants to listen to me. And I just had an argument with one of my coworkers in the lunchroom, and I've really got to get caught up and I got to get things done on time. So excuse me, Jen, what's the reason for your visit today? I mean, can't you just feel the anxiety going up? No, I didn't say anything that was angry or mean, but a person living with Alzheimer's or dementia is keying mostly off of your facial expression, your tone of voice, and your body language. So now that you know that, I get it. Days can be frustrating. I get it. You can get behind schedule and that can be difficult. But sharing that level of frustration with a patient who has cognitive impairment is not going to make that visit any better. Next one, approach from the front, identify yourself, and keep good eye contact. You know, when I'm in my dentist office, and I'm leaning in that chair, my head is to the door, so I can't see who's coming in. If I was a person with Alzheimer's or dementia, trying really hard to process everything that's going on around me, that might be a little unsettling when I can hear people out there in the hallway. People are coming in to check my x-rays and leaving. Might be a little unsettling. So when you enter the room, if their head is behind you, come in front of them. Let them see you and let them see the smile on your face, by the way, and then approach them. As you approach them, identify yourself. I'm Jen, your dental hygienist today. Colleen, it's so good to see you. And if possible, get down on their level, right? So if they're lying in that bed and you're talking down to them, you're literally, number one, talking down to them. And number two, when you get on their level, now they can see the smile on your face. Now they can read your body language. And their blood pressure goes right back down. All right. Speak clearly, use positive body language, and allow those 20 seconds to respond. Speak clearly and calmly. Allow the person time to understand the information and respond. Use simple sentences. If the person doesn't respond after 20 seconds, or if the person's face goes blank, so you know they've lost their train of thought, then just repeat yourself. Use simple and relaxed gestures or body language when you can. And it may help to find a quiet, less distracting place to talk. If you have one of those exam rooms with that popular music playing overhead, see if you can shut it off in that room, right? Just to make it a little bit more relaxed. Be patient and supportive. Let the person know you are listening and trying to understand. Show them that you care about what they're saying and try not to interrupt. Use supportive statements like, this is no problem. You and I are in this together. I've got nothing more important to do today than to help you, to be with you. All right. And if they get distressed, respond calmly to their distress. People with dementia have trouble remembering their personal or health information, the reason for their visit, or even how they got to the clinic. If someone looks confused or distressed, let them know that you're listening and trying to understand. Use a calm voice, a smile, and reassure them it's okay. Encourage them to continue and offer to help. And if the person becomes upset, number one, stay calm. Number two, apologize. I am so sorry. Even if you didn't do anything wrong, just the fact that you're taking it on yourself says that they're not the problem, and it helps them calm down. And then if all else fails, try, let me go get a supervisor. I am so sorry I've upset you. Let me go get my supervisor. Maybe we can get this settled. A couple of things I want you to avoid. Avoid criticizing and correcting. If it doesn't matter, it doesn't matter. So a person living with Alzheimer's or dementia, if they tell you that, no, I haven't brushed my teeth in the last 3 months, but you can tell by looking at their mouth that they're doing a great job on oral hygiene, or vice versa, don't argue with them. Just continue to give them the same safety tips and the same healthcare tips that you've given them every other time. There's no need to criticize. There's no need to correct, and try not to argue with them. There are times when a person with dementia is going to say something like, I'm going to stick my dentures in the bleach to get these stains off of them. And you need to stop that, because that might not be very healthy. And so then you need to maybe offer some other solutions like, I've got something that works even better than bleach, right? And then, but don't argue with them. Don't say, oh no, you better not do that, because you've just ratcheted up that conversation again. So far, we've talked about signs and symptoms and some communication tips. We now know that calm and slow is good, and correcting and arguing not so good. Next, we're going to do an activity. I'm going to have you guys do some of the work for a few minutes that maybe can help us understand the impact of dementia on planning. So, like communication, planning is a very important thinking skill that is impacted by dementia. Without it, even seemingly simple tasks that we try to do every day may be confusing or overwhelming for someone living with dementia. And you might be surprised at how complicated seemingly simple tasks actually are. So let's find out. We're going to, how about, no, I was going to break you into smaller groups, but especially since Jess and Lolly are having trouble communicating, why don't I'll just stop my video and walk away and let you guys talk amongst yourself for a few minutes and work on this everyday activity. And so what I want you to do is create step-by-step instructions for a familiar task, checking into your clinic for an appointment. So let's imagine that you're the receptionist and you have a brand new patient coming into your clinic tomorrow, checking in for an appointment, and they've never been there before. I'd like you to write step-by-step instructions for this new patient. This person, we don't know if this person has Alzheimer's or dementia or not. We just want to create, what are the steps? So the person has now entered your building. I want you to write down all of the steps that it takes for them to get to your office and get checked in with the receptionist. And then you can end your list when they are now sitting in the lobby waiting to be called for their appointment. I'll give you like 5 minutes to do this. Why don't you work together and create that list? And please remember to number your steps as you go. Does anyone have any questions about what you're going to do? All right, you guys, I'll be back in 5 minutes. Let's see where we got.
Okay. Well, I don't know about you, but my dentist's office is in a bigger building. So just getting in the door does not get me to the actual office.
Yeah, and it's the same thing with ours, and not a big building, but it's on the second floor. And so I think that the first step would have to be, if the person is entered the building already, then the first step would have to be directions, if nothing else, because you don't have there isn't necessarily a receptionist, be written directions, clearly written to to go to the elevator or the stairway, and probably the elevator, and to go there and to get into the elevator. So you got the first step would be to written directions. to the elevator, I think. And, or, you know, if it's on the first floor, then directions with arrows, you know, if it's right there when you open the door, directions with arrows, very clear directions. In other words, you know, this is where it is, not just something in small print, but clear.
I agree. So let's say I've found the elevator and that I'm going up to the second floor. I've got to push the up button,
Well, I
right?
think that has to be also a note. I mean, if we're making any kind of assumptions in the elevator that says very clearly, you know, the dentist office, and I don't know how they do that, but they'd probably have to put a sign in there, push the up button, you know,
Yeah.
directions.
Okay. So if we get in the elevator, and Michelle, you're muted.
Thank you. You have to push the button for the floor that you want to go to.
Okay.
And then when the elevator doors open, you have to come out and then either go left, right, center.
So find direction getting out.
Yeah, so there'd have to be, again, signs, whether they're just in large, clear print, not with a lot of other garbage on the signs. It says dentist office or the name of the dentist on there somehow. So, yeah, in the directions.
So then when you get to the actual dentist's office, you probably have to open the door and walk to either the waiting place where you wait, or to, if nobody's waiting, then you have to walk to the reception desk and say your name. And typically people then ask you for your insurance card or whatever. Oh, you probably have to say not only your
Would
name,
we
but
have to,
like,
before we did that,
mm,
would we have to, based on what's happened during COVID, follow the signs very often that they put on the floor to stand? Would that have to be part of the direction, is follow? Because that's, they say, you know, stand here while you're waiting, kind of thing.
good point.
Yeah. So I think we'd have to put that in there, at least for now, until things, you know, until that changes. So, but you're right, the reception is next then.
Okay.
So if I have to get my insurance card out, I don't know about you guys, but I typically forget that that's something I'm gonna have to do. So I usually have to dig in my purse for that.
Yeah, that takes me a while.
Well, I think too that, assuming that the receptionist has some kind of a personality, and that, you know, that she would, to follow, maybe even to add in there, to follow the receptionist instructions with regard, follow the receptionist instructions. I guess that's kind of an issue. I was just thinking about that. I think that if I were planning this for a dental office, the whole thing would be to identify if somebody has a dementia problem. To identify, the receptionist really has to be the one to identify and pass the word, to start kind of passing the word down the line. But I think, yeah, anyway, okay, I'm talking too much here.
Okay, so I got it. You've gotten her now. The new patient has gotten to the reception desk and gotten out her insurance card and given her name. So you're almost there. I mean, she might have a little bit more paperwork to do. Did someone number the steps? How many steps did we come up with?
Well, I was at 13.
Okay.
I didn't number them. I just made notes here, so I did number them, but I came up with fewer, but I don't think I was as detailed. One of the things that you have to do too, following that, is normally they will hand you a piece of paper that says, right now, these are the COVID things, are you sick, that type of thing. But a piece of paper with information regarding your health.
Right.
So,
Right. So yeah, you guys didn't quite get her all the way to sitting down in the reception. But so if we add the well, let's back up a little. Jen, could you tell me what the first step was?
Well, since we started with her just being inside of the building, we said to follow hopefully clear signage to either get to the elevator or down the hall so we could even find the office. And since my dentist is upstairs, we got as far as the elevator on the
All right.
first step.
So good point. So the first step is to help that client wayfind to the office. And that's probably at least 5 or 6 steps, because assuming we're going to the elevator, we walk to the elevator, we push the button, we wait for the doors, we step in, we wait for the doors to close, we turn, we push the button, we wait. So probably easily 5 or 6 steps just there. And then we get out of the elevator, and now what are we doing?
Looking for that same signage, trying
Oh,
to decide if I'm going to the left, to the right, or straight ahead.
all right. So then we open the door, we walk in. All right, and so we got as far as 13 steps. So probably by the time we get our wallet out, get our insurance card out, put the insurance card back, put it back in our wallet, put our wallet away, probably, and then answer all those questions, we've probably got 20 to 22 steps would be an approximate guess. So how many of you thought it would take 20 to 22 steps to register with the receptionist for an appointment? Right, who knew it would be that complicated, right? And look at how hard, by the way, our brains are working on this. The whole time we're doing this, our brains are processing all the information from around us, all of the signage that we ignore and the signage that we're going to follow. We're taking in the sights and the sounds. Heaven forbid, if there's a black mat on a white floor and we have to worry about whether or not we're going to fall. So there are a lot of steps involved in even something this simple. So then what does that mean? If a patient in your clinic is having trouble struggling with this simple task of entering your building and registering for their appointment, what could be done to support them? Not take over for them, but to support this person and their abilities.
well,
Well,
I think that
talk-
we look, go ahead. I'm sorry, go ahead.
No, you go ahead. I was gonna say what you said, so we might as well hear it from
Well,
your mouth.
I think that there has to be some very clearly and simply written signage throughout to make sure, because you're not going to find floor walkers to direct people to the office. So I think that the signage has to be clearly, simply written probably in large print, because vision is also probably an issue.
All right. So then we've gotten the person into the office, and now they're standing in front of the receptionist and they're having trouble following in the instructions. What do? The answer is so simple. Can I help you? That simple. I don't know where I put my insurance card. Well, I keep mine in my wallet in my purse. Have we checked your wallet? Oh, I don't know. Let's look together. And it's simply a matter, not hand me your purse, I'll look for it. Please. These people are nervous enough already, and now you just stole their purse. So walk alongside of them, help them step by step, but don't take over for them. All right. And then once they're having trouble and you've helped them out, then how are they going to feel? Respected, supported, safe, maybe? All right. So what did you learn from this activity?
that
Things
there's
are more complicated than they seem.
yes, exactly. There's more steps into everything than what we probably recognize.
Absolutely. And that person living with Alzheimer's or dementia is doing the best they can to try and keep up with all of it. So most people take simple day-to-day tasks for granted, but when you actually break them down like we just did, they can be a whole lot more complex. And for someone with dementia who has problems with memory and communication and planning and decision-making, any one of those steps can become a challenge. But with our support, it is possible for them to continue to perform these daily tasks. If we can identify the steps of the task, we can simplify it or offer to help where the person is struggling. By doing this, we empower them rather than take care of them. And they could be more successful and more. So if you turn to page 7 of your handout, I want to spend some time on how to create a dementia-friendly work environment. We've talked about some of the changes that are going on with this person living with dementia. We've talked about the visual changes and the cognitive changes, but you have the opportunity to make life easier for someone with dementia. Just like supporting someone with the individual steps of a task, there are little things you can do in the physical environment to make it safer and more welcoming to someone living with dementia. And let's talk about some of those. First of all, the entrance. The entrance should be clearly visible and understood as an entrance. Make sure that the glass doors are clearly marked on the glass door. Avoid rugs because they create optical hazards as well as tripping hazards for people with poor depth perception or visual contrast issues. Signage. I heard you say this when you were talking about finding your way to the dental office. Finding your way around should be clear. Use a bold type and should have contrast between the words in the background. None of that frosted glass on glass stuff. For a person with Alzheimer's or dementia, that's just a design on the glass. Signs should be mounted to the doors and the spaces they refer to, not mounted next to the door. Signs should be at eye level and well lit. Avoid using highly stylized abstract images or icons on the signage. Think about placing signs at key decision points for someone who is trying to navigate the premises for the first time. Signs for getting to and from public restrooms are particularly important. Lighting. Lighting goes back to those visual changes that they've got with depth perception and with peripheral vision. So entrances should be high powered and include natural light whenever possible. Avoid pools of light and dark areas because those dark areas, those deep shadows can look like holes for someone with vision issues. Strategic use of lamps will help illuminate those shadowed areas. Flooring should be plain, not shiny, and not slippery. Bold patterns on carpets, curtains, or wallpapers can cause perceptual problems. Plain walls and flooring are recommended, and using black rugs or mats avoid using black rugs or mats because those again are going to look like holes. And we just take that for granted. Step surfaces can cause confusion. Consider adding tape or non-slip stripes. Pathways should be wide, uncluttered, and those directional arrows John was talking about, especially on the floor, can be very helpful. If possible, it would be very helpful if you could create a unisex or a family bathroom. If I'm coming to your appointment and I need help using the restroom and my husband is with me as my care partner, he might feel uncomfortable going to the ladies' room with me to help me, and I might feel uncomfortable going to the men's room with him to help him. But if you have a family bathroom set aside somewhere, it can give us the privacy and the comfort and assurance that we need. Creating a calming place by reducing overhead announcements and that very nicely popular music that they play. and other background noise. Maybe play calming music if you're going to have music, or adding soothing images, or even individualized aromatherapy, offering something soft or smooth to hold on to. Using weighted or X-ray blankets may also help patients if they are anxious. Quiet is a good thing for someone who's trying to take it all in. So quiet areas for someone who may be feeling anxious or confused can help that person recover enough to independently complete whatever they were doing. Offer comfortable seating away from doors, elevators, hallways, and potential hazards. The layout of the area should be free of clutter and arranged to make it easy to move around. Minimize the physical transitions, such as, check-in, rooms, billing. As few different spots that they need to go to as possible is better. And then be aware of potential hazards, such as hot coffee pots or area rugs, or those silver trays that have those pokey things and that are next to the chair. Just be aware that those could be a potential risk for someone with dementia. This would include leaving a tray of sharp tools in the room with an unattended patient. They may try and get up out of that chair, may reach for that arm on that tray to get up, and may hurt themselves, not realizing there are implements there that can hurt them. So think about this list and your physical environment there at your dental clinic. What are some barriers someone with dementia might have? And can you think of 2 ideas you have right now that could make your office or clinic space more dementia friendly? On page 8, there's room for you to write down your 2 ideas. I don't want you to miss those moments now that we've gone through the list. I'm going to take just a deep breath here to let you write down any ideas you might have. All right, so let's see if we can't put this all together now and see how it would work. I'm going to give you a case study and you have it there with you. I'm going to very briefly put it here on the screen. There. An 85-year-old who has been a patient at your clinic for the past 15 years arrives for his dental appointment, which is actually scheduled for next week. He appears confused and upset and says he's sure his appointment is today. He lives about 8 miles away, but reports it took him a few hours just to find your office. He said he got lost and had to stop a few times to ask for directions. Your office manager notes he showed up last week as well, was confused about the timing of his appointment, and got upset when his appointment date was clarified. She said she gave him an appointment card with the correct day and time clearly written down, which he put in his wallet. Not that that matters now, because here he is, thinking he has an appointment. So I am going to do the same thing again. I'm going to give you guys 10 minutes to problem solve all the different ways you can help this man and resolve this situation for him. And I'm going to come back in about 10 minutes and see what you came up with.
Okay, what should we do first?
Well, one of the things that I was thinking about when I read this was, I don't know whether it should be first or not, but is how do you handle that when somebody is not there for the appointment and they obviously have whatever kind of issues, dementia issues that he has. I really wonder if we're looking at something that requires more than what the dentist office can handle, or what you can handle at that point. One of the things that I did think was that what you have to do, rather than just handing him a card, would be to tell him, and I don't know whether it would work, that when his appointment day, for his appointment day, you will call him on that day or at the day before, and then even at that, call him the day of the appointment. I think that, that might be something to do. Now they do all sorts of things with phones and that type of thing and email, but that probably wouldn't apply in this case. But I would think a phone call.
Well, I think that's a great idea for the next appointment. But
yeah,
he's here today.
Yeah.
Right. And they say he's getting agitated because he says, that he's here on the right day and I've got it, the receptionist has got it wrong.
Yeah.
So
I wonder if the thing to do would be to have some kind of a quick conference between the staff and make a decision based on whether or not you could find it. First of all, it'd be based on whatever his issue is with his teeth, but also based on who you could find to help him. If it's a teeth cleaning, maybe you just pull one of the hygienists and ask somebody to wait, the next person in line or whatever. That might.
yeah, I think I would definitely see if we could figure out how to work them in. I think the first thing is to try to de-escalate the anxiety, right? Michelle, what would you do?
Yeah, I mean, one of the things that we learned earlier in the presentation was when somebody's upset, to keep a calm, steady voice, to remain calm, even though when someone's really upset with you, it's a really anxiety provoking situation. And, it's very tempting to sort of feel yourself getting escalated, or, the thing not to do, I guess, would be to say, no, you're not here on the right day. And sort of challenge him. We learn that we should avoid arguing. So I think that maybe figuring out together, or just saying that, apologizing. I heard that, even if it's not our fault, just saying, oh, I'm so sorry this happened, how stressful. Let's work together to figure it out. We're going to figure it out. It might be, to me, one thing that is a concern is that, if somebody took a couple of hours to get somewhere that should take 8 minutes, that's a major red flag that there's cognitive impairment on board. And I'd be a little worried about how this gentleman is going to get home. I think I would also wonder if, why he keeps coming, is it that he's forgetting? Is it that he's in pain? And so that's sort of like triggering him to show up at the dentist. I think I might wonder or ask him about that, maybe take him to a quiet place and ask about that, just so that if he is in pain or if he's reporting pain, that might help me know how to triage the situation. Does he need to be seen right away versus do we need another plan? I don't know. These are just some ideas. And there's some texting going on. I really want to hear from the people who can't speak.
Well, it looks like the first one says, good ideas, John. Maybe a calming room and find a way to relax. And then the second one says, good points, Michelle. Could we also ask if there's someone from the family we could call?
It's a great idea.
So I think too, like how John brought up that good suggestion about calling the person with a reminder day of, those types of things on planning for next time. One thing I think we could do as a dental practice is to have an emergency contact on the original sign-in sheet, right? So that maybe 10 years ago or 15 years ago, I think this person's been coming to the clinic for 15 years, we could just update that every visit and say, oh, is Sheila still your contact in case we need to get in touch with somebody? So that,
That's probably a good idea for all our patients,
Yeah,
not
yes.
just ones that are confused, but you never know what could happen. And if we don't have anyone to call, I mean, that could be really a stressor for all of us in the practice.
I
Yeah,
agree.
even anybody, even if there's a reaction to some kind of
Right.
medication
Yeah,
or even Novocaine or something, it's
yeah.
I
People
think
might be,
one,
oh,
go ahead.
sorry, I was just gonna say, people might be more likely to give us that information if they know we're asking everybody and not just
Yeah,
people we think have something wrong with them.
Yeah, and that could be even posted, please update your emergency information. So like you said, everybody would see it. Maybe this person would not have paid attention to it, but it would be there, so there wouldn't be any issue
Right,
about
so
it.
you
We
don't
only
feel bad.
asking certain people, yeah.
Right.
no
One of the,
discrimination. Yeah.
One of the things that I thought about was, and it depends, of course, on where this practice is, but if it's in the metro area where you might have metro mobility, maybe the idea would be if you are treating this patient while you're doing that, is to call and set up an appointment to have him picked up and brought to his house. He obviously has some kind of money. I don't know what Metro Mobility costs, but to pay for the ride, that just a thought.
I
Yeah,
think too, is this as a staff, we have to determine, is this an emergency? Because in some ways it is, right?
Yeah.
And so do you call, I don't know, I mean, do you call the police or some kind of authority
Yeah.
figure to help? Or, at least like report it as a vulnerable adult?
Yeah.
I don't know. What
right. Or
what
an
do other
at-risk,
people think?
reporting an at-risk driver for later. I mean, that's not gonna solve our problem right now, but for him, I mean, clearly he needs an on-road driving test.
Yeah.
The other thing I might think of that Colleen had said earlier at the very beginning of class, she talked about this, when we see red flags, it being an opportunity to talk to somebody about seeing their primary care provider, about getting a workup. And so it might be a good opportunity to sort of talk about to this gentleman about what the changes we're noticing in his thinking skills, and ask what he's noticing, and then ask if we can talk to his primary care provider about some of our concerns and see if we can get to the bottom of it so that we can address his symptoms. Because as providers, I think it's our responsibility to find out what's at the root of health issues when we see them. So that might be something that we need to talk about, and the door opening to talk about it.
You're right. There may be some even legal responsibilities there dealing with vulnerable adults. And those are, some of the issues that would come about.
An amazing discussion, you guys. You are great. And no wonder this is such a well-received dental practice, because you really have a heart for your patients, as well as helping keep them safe and move them forward. As I see this case study, there are 4 issues, and I think you guys covered them all. Number 1 is this gentleman's anxiety level. How do we find a quiet place thank you, Lolly and Jess, for that, where he can be comforted? And the staff interacting, we're so sorry, we're going to solve this, we'll figure this out. All of that is important to his state of mind. And really, if he became distressed last week, we don't want a repeat of that. So excellent work there. Then the next step is, what do we do about this appointment? Can we squeeze him in now? Do we need to keep him to his appointment next week? How can we do that? And maybe getting the doctor out there to talk to him that says, gee, Mr. Johnson, I'm glad I'm so proud of how you're concerned about your dental care. We are too. We don't have any availabilities today. I'm so sorry. By the way, one thing I'm curious about is, who thinks of their dentist 2 weeks in a row? I mean, normally we go to our dentist every 6 months. So is there a reason this man keeps thinking about it? Does he have dental pain? Somebody needs to find that out. Maybe there's something wrong that is compelling him to this appointment earlier than usual. And then the big issue for me is, how does he get home? And I think you've talked about some good strategies, seeing if you can find a caregiver, see if you can use Metro Mobility, see if you can call the police and have the police escort him home, right? Because now that you know he has driving issues, and it could be a potential liability for you. And then I love that you got to the final piece is, somehow somebody needs to intervene on this man's behalf, because if this has happened to him on his dental appointment, this is happening to him other times as well. And so filling out that vulnerable adult report, finding someone who can come alongside of him and do a much more in-depth analysis of what's going on and get him the ongoing support that he needs is going to be key to his safety going forward. So I think you guys hit all of the major points, and I'm really excited. I feel like we really made some progress today. So I just want you to know, as we're wrapping up, that there are resources available to you. You do not need to be the do-all, end-all of Alzheimer's and dementia because you spent an hour and a half with me. So first of all, there is the Alzheimer's Association, which is an amazing resource, not just for people living with Alzheimer's or dementia, but their caregivers, their care providers, the professional staff, the neurologists that are serving them. They have caregiver support. They have all sorts of services and are up to date on the latest research going on around Alzheimer's and dementia. And so on page 8 of your handout is both the 24-hour phone number and the website for the Alzheimer's Association. And I want you to feel comfortable knowing they're an excellent resource there for you. Another amazing resource here in Minnesota is the Senior Linkage Line. They simply serve as a referral source. So if you've got someone looking for home health care, if you've got someone looking for memory care, if you've got someone looking for transportation services, you can just call the Senior Linkage Line and they'll find those service providers that are in your specific area or that patient specific area to provide those services. And I know there are lots of other resources out there, but for a person living with Alzheimer's or dementia, if you hand them a list with 30 different resources on it, it's too complicated and they're just going to set it aside and never look at it again. So if you have a specific resource that you know that is in your area that you know fits this specific need, certainly give them that, or give them the Alzheimer's Association or the Senior Linkage Line. And then for you as providers, there is the Act on Alzheimer's website, actonalz.org, that has trainings just like this one that can offer simple, practical advice for people working with and caring about people living with Alzheimer's or dementia. So to recap, we've spent some time together today and we've covered a lot. We've talked about some facts about dementia and the early warning signs of Alzheimer's disease. We've talked about communication tips and strategies, and we've done a planning activity. We've even talked about creating a dementia-friendly environment and done that case study, which you guys aced. And we've talked about some resources that support people living with dementia. As you learned today, there are a number of reasons why a patient may appear confused or acting differently than usual. Our role is to help, to notice, to support the patient and make sure they feel supported. If needed, to conduct or refer the patient for evaluation, telling them maybe you need to contact your primary care physician. Can I contact your primary care physician for you? But we can also help by slowing down, by adjusting the environment and connecting patients and families with the resources they need and support. I promised that we'd end with a call to action, and so we will. In the box on page 8 of your participant guide, I'd like you to write down just one idea you learned today that you will implement in the next month, help your workplace be more dementia friendly. And I'm going to give you just a minute to do that. And then I'm going to ask you if you would be willing to share that idea. Oh, Michelle said she's going to review our intake forms. Thank you. Make a quiet room available. Thank you very much. I think that is key. Even if it's a small conference room if you're in a large building and you just have a small conference room, you can reserve. Clear signs. Thank you very much. Give more time. Yeah, that 20 seconds is key, isn't it? And you'll be amazed at how people begin to relax when you have some grace around their needing that more time. All right. So finally, and maybe most importantly, I want to thank you for participating in today and for your commitment to providing excellent care to your patients, especially those with cognitive impairment and dementia. For those clinicians in the room who are interested in advanced dementia training, visit the Act on Alzheimer's website at actonalz.org. In the next few days, you're each going to receive an email with a link to an evaluation form to evaluate this presentation that we did today. Please complete that. And then once you do, you will receive in turn either a certificate of participation or a CEU, depending on your needs. And I hope that is helpful to you going forward. We have another 10 minutes or so if you have time. And if you have any questions we can answer, I'd be happy to help, and maybe others can help as well.
Well, I don't have any questions, but I have huge praise. This has been so informative and super helpful, Colleen. Thank you.
Yeah, your presentation was excellent and clear, and I happen to know that you're a Toastmaster, so that shows. So anyway, I just think it's
So is John. In case you're wondering, John and I have had this conversation. We are both
I'm not as accomplished, I don't think, as you are. I thought you did it. I thought you really did a professional presentation, and I think the material is good. So.
Yeah, I did not create this curriculum, but I have to say I love it. I think it is empowering. I think, yeah,